An acute coronary syndrome. The heart is sick and I don't know why. What does it mean? Does it mean an infarction? Could be. Acute coronary syndrome, ACS, does it mean angina? Yeah. Is it an infarction? Could be. Unstable angina? Could be. Non-ST segment? ST segment? I don't know. Acute coronary syndrome means that you have some sort of chest pain that's ischemic in nature, and I'm not certain yet whether it's an MI. I don't have enzymes. So acute coronary syndrome, basically they're thrombosing. It could be unstable angina. Remember, unstable angina by definition was new pain, worst pain, rest pain, new pain, worst pain, rest pain. It could be an infarction without ST elevation. You could just have pain. Pain, go away, come again some other day. So pain, unstable angina, aspirin, heparin, beta blockers, oxygen, morphine, nitrates. But aspirin, heparin, beta blockers, aspirin, heparin, beta blockers. Non-ST segment elevation. Aspirin, heparin, beta blockers. What's the difference in the management of unstable angina and non-ST segment elevation MIs? Not much. They both should be catheterized. Third option, a myocardial infarction. What, therefore, is the difference between the management of the person who's having quote-unquote unstable or unstable angina, okay, non-ST segment elevation MI, and an ST segment elevation MI? Which of these people is going to get an aspirin? All of them. Which of them gets a beta blocker? Atenolol, metoprolol, metoprolol, atenolol, atenolol, metoprolol, metoprolol, atenolol, all of them. Which of these should get a statin? All of them. Oh yeah, oh yeah. So what's the difference? Well, what's the difference is this. You can't tell these apart without an EKG and enzymes. You can't tell them apart without an EKG or enzymes. Cannot do it. That's why we have the term acute coronary syndrome, because it means you have a person with ischemic disease and you can't tell them apart without an EKG and enzymes. Now, the only one of these that's different is stable angina, and stable angina is by definition a particular pattern of pain. It's a particular pattern of pain. And the particular pattern of pain has to do with whether it's been changing or not. Well, look at this location of the pain. You see how it's substernal or in the back? Substernal. Not left-sided pain, not right-sided pain, substernal. Substernal pain is ischemic. Left-sided or right-sided pain is generally not ischemic in nature. Unstable angina, non-ST segment, non-ST segment elevation MI, non-ST segment elevation MI. How do you tell them apart without an EKG? You can't. As a matter of fact, they could both have the same EKG. Okay, as a matter of fact, you can't tell unstable angina. What's the difference between these two? What is the difference between these two? Has to do with CK-MBs or troponins. A CK-MB and troponin here is normal, and here it's elevated. How do you tell them apart? Now, it's elevated here too, but at least you can tell them apart with an EKG. You can tell them apart with an EKG. The symptoms, remember, ischemic pain comes first. Sore, squeezing, tight, 10, 15, 20 minutes. I get an EKG and markers. The markers are troponin and CK-MBs. Troponins and CK-MBs don't begin to go up for 4 to 6 hours. The markers are normal. Well, I got a story like an MI, but I'm not making enzymes. I got a story like an MI, but I'm not making enzymes. That's unstable angina. I got a story like an MI, but I'm not making enzymes. That's unstable angina. Now, I got a story like an MI, but no ST elevation. Wow. Positive troponins. That's a non-ST segment elevation MI. That's the difference. That's the difference. Aspirin, beta blockers, hesperin. Aspirin, heparin, beta blockers. What do? Aspirin, heparin, beta blockers. Now, you see this thing about unstable angina to non-ST segment elevation MI? People who have, by definition, you ready? Unstable angina, excuse me. New pain, worse pain, rest pain, A lot of these people go on to MIs later. New pain, worse pain, and rest pain. Now, you can't tell them apart based on physical. They might have an S4, you can't tell. Now, only half of patients have EKG changes, meaning that the ST or the T wave is not abnormal in an awful lot of people who have serious cardiac damage. Now, the worst thing about unstable angina, how do we know who's going to go over there? How do we know who's going to progress and get sicker? How do we know who needs to be catheterized? Catheterized. What's the biggest thing? The person has pain and the pain just won't go away. Pain, pain, go away. Come again another day, but it won't go away. Time to cath me, time to cath me, maybe angioplast me. Oh, I made positive markers. See that? The longer that pain persists, the more likely you are to progress. The worse the EKG, the more likely you are to progress. The lower the blood pressure, the more likely you are. It's like, oh my goodness, the big bad wolf. Oh, Grandma, what big troponins do you have? Oh, the better to infarct you, my dear. Oh, Grandma, what low blood pressure you have? The better to kill you with septic shock, my dear. Oh, Grandma, I think you should put in your cardiac cath introducer. Can I shave your groin? Oh, yeah, that would be fine. So therefore, how do you know who needs to go on to getting catheterized right now? And the answer is people who have pain that just won't go away. Hey, what are you going to do? Just stay in there? You gave me an aspirin, you gave me a beta blocker, you gave me heparin, you gave me aspirin, beta blocker, heparin, morphine, oxygen, nitrates, ACE inhibitors, statins, aspirin, beta blocker, heparin, morphine, oxygen, nitrates, beta blocker, statins. You gave me all that and I still got pain. I'm going to die here. Cath man, cath man, cath man, make me a dream. Make me the best angioplasty I've seen. Put in a stent so the guy can pay the rent. Oh, cath me, yes, cath me. Oh, cath man, I'm hypotensive now. I'm gonna be buried under a plow if you don't cath me. Ah, yes. That's it. Shave me and cannulate me. Oh, and the worst. You see all these things? Prolonged chest pain, markers, EKG changes. These are all people who are very sick, hypotensive. The worse you are, the more likely you are to need to be cathed. Low ejection fraction, these are being repetitive here. So the worse you are, what happens if you had previous bypass? Well, this is a person who's going to get sick again. Remember, you see diabetes? The sicker the heart, the more likely you are to need to have an intervention. The same thing with chronic renal disease, because renal disease means you can't tell if it's a false positive troponin. Troponins accumulate in renal failure. People with renal failure have higher troponins than other people. What are you going to do about that unstable angina? You're going to do this. You're going to give everybody an aspirin. Everybody gets an aspirin. Everybody gets an aspirin. Everybody gets a beta blocker. Everybody gets a beta blocker, an aspirin, a nitrate, a morphine, and oxygen. But only ST elevation with TPA. Less than 12 hours of chest pain and ST segment elevation. Remember, ST elevation only. If you have non-ST elevation, no thrombolytics. No thrombolytics. Everybody gets aspirin. Remember, clopidogrel's main indication, I get stented, clopidogrel. I get angioplasty, clopidogrel. I can't tolerate aspirin, clopidogrel. I can't tolerate aspirin, I get stented, I get angioplasty, clopidogrel. Clopidogrel. Now, antithrombin therapy is heparin. Heparin is the single biggest thing that you do in both of these. Heparin here, heparin here. And the reason that these both get heparin is that these are a coronary artery that's in the process of clotting. These are coronary arteries that are in the process of clotting, of closing off. Heparin prevents clots from forming. Heparin prevents clots from forming. Here, in an ST segment elevation MI, The clot has already formed. That's why we use thrombolytics to bust it all wide open. So heparin is to prevent the clots from forming. Glycoprotein 2B3A inhibitors. What's different and unique? Here, catheterized glycoprotein 2B3A inhibitors. These are extraplatelet drugs. Eptifibatide, abscissimab, tirofiban. Eptifibatide, abscissimab, tirofiban. They're extraplatelet drugs. When are they indicated? Non-ST segment elevation MI, worse unstable angina, gonna get cath, gonna get angioplasty. How do I keep you from restenosing? Glycoprotein 2B3A inhibitors in the worst people. Remember, beta blockers are for everybody. Beta blockers are for everybody. But thrombolytics are not. Thrombolytics is not in a person unless they have an ST segment elevation MI. Well, let's see what else is different is nitroglycerin for everybody. So beta blockers and nitrates. But you notice I didn't put nitrates on top. Why didn't I put nitrates on top? Why are nitrates down here? Morphine down here? Oxygen down here? Because morphine, oxygen, nitrates don't lower mortality. Aspirin lowers mortality in all. Beta blockers lower mortality. Thrombolytics lower mortality only in ST elevation. Heparin lowers mortality in both of these. Mortality, mortality, mortality. You bitter hug of mortality, I draw you near. Tell the physician and the priest to go home. If you want me again, look for me under your boot soles. You shall not know who I am and hardly know what I mean. Failing to fetch me at first, keep encouraged. Pausing one place, search another. I stop somewhere, waiting for you. Well, we certainly can see there's a lot of overlap here in between these managements. Well, invasive management is what you do when you have this person who's clotting, right? Well, you have this person who's clotting. And unstable angina is very similar as well. Well, what's the difference between this person here, this? Well, these are a matter of severity. In other words, the person with unstable angina may be clotting off. He's getting worse. Worse pain, new pain, rest pain, worse pain, new pain, rest pain. But the person with a non-ST segment elevation has actually clotted off to the point where they've made troponins. Here, you're slapping me around. Here, you made me bleed. Here, you're hurting me. But here, you're necrosing me. And here, I have an infarction, I'm going to die. This is progressively worse conditions. They all get aspirin, they all get beta blockers, they all get nitrates, morphine, oxygen. ST elevation MI, we just said. Thrombolytics, angioplasty, thrombolytics, urgent angioplasty. But everybody with unstable angina and non-ST segment elevation MI, both of these people should get CAF'd soon. Why? Because we like to pop that clot open before it gets worse. So that's why it says, you see these phrases here, look at the slide. Early coronary angiography and revascularization. Revascularization means two things. Angioplasty and bypass. Angioplasty and bypass. This is an angiogram. This is a clot. You see it's darker there and it's lighter there? That's because there's more blood here and less blood there. You get a catheter in there, you pop it open. If there's several of them, you pop them both open. If there's three of them, you bypass. You bypass the angiogram. Now, we used to say this term Q wave and non-Q wave. We don't use that anymore because I can't tell if you're going to form a Q wave until 2 days from now. Everything in ischemic heart disease has got to be earlier than that. We can't wait for the Q wave in a day, 2 days, 3 days, 5 days. I got to know now, man. Because I got to go pop you open with a catheter before you develop a Q wave. I'm not going to wait for you to get a Q wave. So the symptoms, wow, look at that. Substernal chest pain, pressure. Do you know that the symptoms of this one is the same as the symptoms of these two? That's what the slide says. It says, the slide says that the symptoms are the same as everybody else. You see this slide? This is a $5 way of saying, oh, it has the same symptoms. Another way of saying this slide, in the Conrad-Fisher way, you could take that whole slide and translate it out to can't tell the difference based on symptoms. The diagnosis. If you don't say EKG, you get sucked out of the test room and shot out on the street. I'm over there with a mouse in my hand. How'd I get here? Because the patient has chest pain. You didn't say they said EKG, man. The symptoms, but the symptoms can't distinguish. The EKG. Remember, these cannot be distinguished without an EKG. Elevation of 1 millimeter. Now here's where we start to refine it. We start to refine it and we say ST elevation. Well, how much ST elevation? 1 millimeter. 2 leads. 1 lead of anything is irrelevant. 1 lead of anything is irrelevant. It also means that you don't need the markers. You don't need troponins and CKMBs to tell you that it's an ST elevation MI. The indications for thrombolytics are not troponins and CKMBs. I can't wait for them. Thrombolytics are good for how long post-chest pain? 12 hours. If the troponins are not going to elevate for 6 or 8, it's too long. It's too long. The other thing is the mortality benefit with these drugs in the first 2 hours, 50%. Your diagnosis is based on EKG, not enzymes. Well, let's hear some rough correlation here. Inferior wall is 2, 3 in AVF. The inferior wall is leads 2, 3 in AVF. The inferior wall is leads 2, leads 3, and AVF. They're like cameras looking up at the bottom of the heart. Well, the lateral leads, like cameras looking at the heart, lead 1 is looking from the side. AVL is looking from the side. V5 and V6 are looking from the side. And where's V2, 4? See this anterior wall here? Where's the anterior wall? V2, 3, 4. V2, 3, 4 are looking at the anterior wall of the heart. Now, EKG correlation with anatomy is approximate at best. EKG correlation with anatomy is approximate at best. We do it mostly because it approximates mortality, and really anything that gives you ST elevation in 2 leads of a millimeter is good enough. This is ST elevation, this is ST elevation, this is ST elevation. That's normal. This is elevation, this is elevation, this is elevation. That's normal. An inverted T wave in AVR, in V1, excuse me, inverted T wave in AVR and V1, in AVR and V1. The inverted T wave in AVR and V1 is normal. ST elevation, that's the baseline. ST elevation, no. That's a little bit of depression. Wait a second, you see that ST depression? Well, that's elevation, that's depression. Which one do I pay attention to? The worst thing, ST elevation. You pay attention to the ST elevation the most. Why? Well, it's like this. You go outside. You go to the parking lot. You're very upset. Someone has scratched your car with their keys. You're getting very angry until you notice someone has removed the motor. And that's what this is about. ST segment depression is ischemia, but ST segment elevation is an infarction. Which one do you pay attention to? The worst thing. You pay attention to the worst thing. That's bad too. Oh my goodness, look at all this evil. I'm surrounded with evil. Elevation, elevation, elevation. Now, what are we going to do? In the beginning, what happens is you get ST segment elevation. And then what happens is that eventually you get Q waves and T wave inversion. So that means it starts with ST elevation and progressives to Q waves and T wave inversion. However, all we really need is this one. You see that? ST elevation, because that's telling us thrombolytics yes, thrombolytics no. What do we do differently based on the presence of Q waves? And the answer is nothing. What do we do differently based on the presence of Q waves? Nothing. Oh, there's the blockage, there's the plaque. Whoa, there's the blockage, there's the plaque. Time for an aspirin, time for thrombolytics, time for clopidogrel, morphine, oxygen nitrates. ST elevation MI. You put them on a monitor. Well, what is the most common cause of death acutely for an ST segment elevation MI? What's the most likely cause of death? And the answer is arrhythmias. The most common cause of death in acute myocardial infarction is an arrhythmia, ventricular arrhythmia in the first 72 hours. We put them on a monitor. Why? Because the most common cause of death is 72 hours. Should we use prophylactic lidocaine for those arrhythmias? And the answer is no. No prophylactic lidocaine. A monitor and a defibrillator nearby is all we need. Now you see this? Oxygen, aspirin, beta blockers, and IV, but the single best one is aspirin, because it lowers mortality the most. So oxygen, beta blockers, nitrates should be given, but oxygen does not lower mortality. Nitroglycerin and morphine don't lower mortality. Within 12 hours, we should be either doing thrombolytics or angioplasty. Now, which has greater efficacy? Which has a greater effect on mortality? Angioplasty or thrombolytics? What has a greater effect upon mortality? Angioplasty, the angioplasty, or the thrombolytics? Which has a greater effect on lowering mortality? What would you want for yourself? The answer is angioplasty. You know, where I work down in Brooklyn, on one side is the largest city hospital in the city of New York, Kings County Hospital. On the other side is Downstate Medical Center, a large state hospital. Downstate does angioplasty. The other side, Kings County, doesn't do angioplasty. They're right across the street from each other. If I was having a myocardial infarction and I was driving into the hospital, I would start shaving my own groin and placing my own introducer and giving telephone consent in order to get myself the angioplasty if I was walking down the street. Why? Because the efficacy is greater. Now, what if the question says no catheterization facilities? Thrombolytics. What if the question says contraindication? Big bleeding. Big bleeding. I've had recent surgery. Can't do it. Can't do it. Can't do it. Angioplasty. I'm had melon, I can't do it. Angioplasty. I got a blood pressure, greater than 180 over 110, greater than 180 over 110. Oh, can't do it. Angioplasty, very high blood pressure, recent surgery, big bleeding, angioplasty. Wow, choice between them. What's the choice? Angioplasty is best. Intervention is best. What does best mean? It means you're going to live longer. Now, between the time you say, hi, I have chest pain, and I'm at the door, and getting the angioplasty, that should be within 90 minutes of coming in the door. Within 90 minutes of coming in the door, I should be getting my angioplasty. Now, it still could be that you've had chest pain for 5 hours, 6 hours, 7 hours, but by the time you come in the door, you should get that balloon in your heart within 90 minutes. Thrombolytics, you might have chest pain for 4 hours, but by the time you come in the door, I should be giving you thrombolytics in 30 minutes. It's like a restaurant, man. They only say, how long has it been since you got here? They don't say, we're serving the person who's been hungriest the longest. When you can't do angioplasty, then the question comes down to this. A patient comes to a hospital without coronary catheterization facilities. Do you give thrombolytics now, or do you wait for angioplasty at the other hospital? And the answer is thrombolytics now. If you're starving, bad food now is better than great food in 2 days. So therefore, the person's ventricle is being strangled. I'm being killed, I'm being strangled. Don't worry, we can transfer you for angioplasty in about 3 hours. Well, I'm being strangled, I'm being strangled, I'm being strangled, I'm being strangled. Thrombolytics now. Stop the strangulation. Thrombolytics now. Stop the strangulation. The sickest heart anterior infarction needs the angioplasty the most. Now, streptokinase and alteplase are two different types of thrombolytics. Reteplase, these are just different thrombolytics. you are highly unlikely that you'll be asked much about the difference between streptokinase, retiplase, alteplase, tenecteplase. The only question that's possible about the difference is which of these, streptokinase, alteplase, retiplase, tenecteplase, which of these should not be given repeatedly? And the answer is, which of these should not be given repeatedly? The answer is streptokinase. Streptokinase is allergenic. Streptokinase provokes an allergic reaction. You shouldn't give it repeatedly. Now, being asked the difference between thrombolytics, that is the only question. The bottom line of reperfusion is you should open up that blood vessel as soon as you can. If angioplasty is best, but if you can't do angioplasty, you should do thrombolytics. Okay, thrombolytics is an alternate, meaning angioplasty is the best. If you have a new left bundle also, ST elevation or a new left bundle, branch block. You ready? Left bundle branch block is associated with ischemia. It's associated with infarction. A left bundle branch block is evil. A right bundle branch block is okay. It's not perfect, but it doesn't mean anything that much. So either ST elevation or a new left bundle is the indication for thrombolytics. If you can't give thrombolytics, we use angioplasty percutaneous coronary. You absolutely can't if you're bleeding, big bleeding. You can't if you've had your head hit, if you've had head trauma and I give you thrombolytics. Head trauma and give you thrombolytics, you're going to bleed in your brain. If you're dissecting and I give you thrombolytics, you're going to exsanguinate in your chest. If you've had a bleed into your brain at any time, it's always a contraindication of thrombolytics. Non-hemorrhagic stroke, a long time ago, you could use thrombolytics. Hemorrhagic stroke, never any thrombolytics. Non-hemorrhagic, you can use thrombolytics. Hemorrhagic, you should not use thrombolytics. If it is hemorrhagic, you're always off. Now listen, recent major surgery, it's kind of like this. It depends on what the surgery. Head transplant, heart transplant, no thrombolytics. Oh, hemorrhoidectomy, I'll take my thrombolytics. Now, prolonged CPR is we think that if you have a lot of CPR, you're going to have an increased chance of bleeding if you're a person who gets thrombolytics. Now, isn't that really the same thing? Yes, it is. Now, peptic ulcer really depends on whether they're bleeding. If you're not bleeding, you might be able to use it. Poorly controlled hypertension means a blood pressure that is above 180 over 100. 180 over 100. So what happens when you have a stable patient? No change in pattern, no change in perfusion needed. Elective catheterization. If you have a bypass, you use a bypass so people have left main or three vessel disease. The sickest person gets the bypass. Cardiogenic shock. In other words, if somebody has had angioplasty, they've had thrombolytics, they've had angioplasty, they've had thrombolytics, they've been repaired, and they still are hypotensive, bypass. Ooh, bypass in progress. Ooh, look at that. Don't do this to me, okay? I don't really want that. You see that? That's one side of his rib cage, and that's the other side of his rib cage. See, this part and this part, they're supposed to be touching. That's a rib spreader. Oh, that's not nice. Ooh, that's teasing. It's like bad dental work. Is there a person under there? I hope not. Oh my God, that looks painful. Antiplatelet. Aspirin is first. And if they say, what do you do first? Aspirin or thrombolytics? Aspirin is first. Why? Because it lowers mortality. Why? It works instantly. Chew it and it works instantaneously. What's the dose on the aspirin? Doesn't really matter. Doesn't really matter. The boards are not going to ask you that dose. The boards generally don't ask dosing. You're off the hook. Clopidogrel, can't tolerate aspirin. Clopidogrel or Plavix when you're going to go angioplasty. Why? Because clopidogrel or Plavix. Clopidogrel, if you're going to get stented, we use clopidogrel because stenting stays open more with clopidogrel. The more you use clopidogrel, the more that the stent is going to stay open. Stent, clopidogrel, keeps it open. Aspirin, heparin, clopidogrel, keeps it open. Now, glycoprotein 2B3A inhibitors are not very useful for ST segment elevation MI unless the person's going to undergo angioplasty. It has the greatest benefit in angioplasty only. Oh, doctor, I've had aspirin, I've had beta blockers, morphine, oxygen, nitrates, I've gotten thrombolytics, I still stayed sick, I still had persistent pain and hypotensive and shock, I got angioplasty, I got clopidogrel, I got stented, I got glycoprotein 2B3 inhibitors, I still have pain, I am swimming around the drain, I am looking for transfer to the eternal care unit. What you gonna do? Emergency bypass. Bypass, when you've tried everything, you've had persistent pain, you failed angioplasty, you didn't get better, emergency bypass. Now, see the stress testing? Not when you have acute pain. That is for afterwards. That is for afterwards. A person has managed to survive his myocardial infarction. A person has managed to survive his myocardial infarction. And you are post-myocardial infarction. Everyone should have a stress test at 5 to 7 days. If the stress test is negative, you use meds alone. If the stress test is positive, you catheterize. Post-MI, you stress them to tell you who needs to be bypassed. You stress them. I'm sorry your inferior wall is dead, but it's dead and the rest of your heart's okay. No point in catheterizing you. Hey, listen, I'm sorry your inferior wall is dead, but listen, the anterior wall's not doing so good either. You better catheterize yourself to see whether or not you need to get a bypass. You do stress testing post-MI in order to tell who needs to be bypassed. And you do a maximal stress test weeks later. What's the difference between submaximal and maximal? What's the difference between submax and max? Submaximal means a lower heart rate. Maximal means 85%. Submax, 70% of maximum. Maximal, 85% of maximum. And it basically tells who, you see that reversible? Reversible ischemia means at exercise, decreased perfusion. At rest, normal perfusion. That's the person to bypass. Now you do all these tests to see who needs to be catheterized. That's what they're for. Everybody goes home. What do they go home on? The guy's ready to go home. The guy's ready to go home, and he goes home. He goes home on an aspirin. Yes, he does. Lowers mortality, lowers mortality. Clopidogrel if you can't tolerate aspirin. Clopidogrel if you're going to have angioplasty, can't tolerate aspirin. Atenolol, metoprolol, metoprolol, atenolol, atenolol, metoprolol, metoprolol, atenolol, atenolol, metoprolol, metoprolol, atenolol. ACE inhibitors. You'd give everybody an ACE inhibitor and you stop it at 6 weeks if the ejection fraction is normal. You give everybody an ACE inhibitor and you stop it at 6 weeks if the ejection fraction is normal. Statins, you give it to everybody and you can stop it if the LDL was really low. But you start it on everybody. Nitrates are good too, and they are to decrease pain symptoms. This is an important question here because there's a question coming up in this, okay? And the question is this: what are you going to do? Oh, look at that, nice mnemonic. Aspirin, beta blockers, cholesterol drugs, diet and diabetes, education. Look at that, A, B, C, D, E. Wow, aspirin, beta blockers, cholesterol, diet, education. How nice. Now, after the patient has their myocardial infarction, after they've received their initial therapy, after they have suffered through everything in the ICU, they're ready to go home. They've had their stress test. They're ready to go home. They're going home with their meds. And the patient's wife comes to you and says, "Doctor, is my husband going to be able to have sex with me?" Question is, how long do you have to wait post-myocardial infarction to be able to have sex? And the answer is, no waiting. Why? Because the amount of myocardial oxygen consumption during sexual activity is much less than a stress test. Next point, the guy develops erectile dysfunction post myocardial infarction. What is the most common cause of that erectile dysfunction? The answer is not the beta blockers, psychological. Psych. The first thing is anxiety. Anxiety is more common than beta blockers as a cause of your ED. Next thing, the guy's got erectile dysfunction and he's going to go on Viagra, sildenafil, Viagra, sildenafil. What medication must you stop? What medication must you stop? And the answer is nitrates. No nitrates with Viagra. No nitrates with Viagra. In combination, they cause hypotension. In combination, they cause hypotension. You ready? No waiting for sex post-MI. What are you staying alive for? Next thing is that psychiatric disturbance, anxiety, I'm gonna die, doc, is what keeps you away from having sexual activity, not the beta blockers. Third is no nitrates in Viagra. Other complications of acute coronary syndromes, ACS. Well, what is the most common cause of death post-myocardial infarction? The answer is ventricular arrhythmias. Ventricular arrhythmias. Now, bradycardia may occur, but bradycardia is not the most common cause of death. Bradycardia, if there's no symptoms, there's no treatment. If there's no symptoms, there is no treatment for that bradycardia. Premature beats, yeah, so what? Premature beats is like male pattern hair loss. Yes, male pattern hair loss. Oh, bahut Buddha, Johnny man. What to do? The answer is find very short women who can't see the top of your head. That's the solution. So what do you do about premature beats? Find someone who can ignore them because there's no therapy for premature beats. No therapy for premature beats. What are you going to do about premature beats? Don't do anything about premature beats. Ready? You will want to give lidocaine. You will want to give amiodarone. You will want to give an antiarrhythmic, but don't do it. But don't do it. Now, tachyarrhythmias. Remember, ventricular arrhythmias kill you. Supraventricular arrhythmias annoy you. Okay? So therefore, it is like people in your own family. SVT may annoy you, but they don't kill you. Ventricular arrhythmias, VTAC and VFib, is how you die. Now, the conduction anomalies. What is the most common cause of a defect as we go from the SA node to the AV node? What is the most common cause of a conduction defect? And the answer is, ischemia. I have developed ischemia and it is starving that myocardial conduction system. I've developed ischemia and it's starving it, so I get AV block. AV block. Wow, normal conduction. You ready? The SA node is the blue thing over here. What a beautiful picture. Isn't that a beautiful picture? This is the AV node, the bundle of His, the right bundle branch, the left bundle branch, right bundle branch, the left bundle branch, and normally it goes from here to here and conducts down. If you have ischemia, insufficient perfusion, you get a block. If you get ischemia, insufficient perfusion, oh, look at this pretty picture. Look at that. That's the AV node. Whoa, AV. Ready? Well, SA, AV, down. SA, AV, down. Oh, isn't that beautiful? Why, I feel I'm having a poetic moment now. There is the symmetry and the poetry of the human body is giving. Can we take a moment to feel? Satyam Shivam Sundaram. How beautiful that is. Yes, wow. First degree AV block. First degree AV block is a prolongation of the PR. A prolongation of the PR. Normally the PR interval is the amount of time that it takes to get from the SA to AV. Normally the PR interval should be somewhere between 0.12 to 0.2 seconds, which is say 120 to 200 milliseconds. First degree AV block, PR greater than 200, PR greater than 200 milliseconds, PR greater than 200 milliseconds. Okay? Oh, PR. Yes, that should be less than 200 milliseconds. The PR. First degree AV block. What is the pathologic significance? It means ischemia. What will I do differently based on first degree AV block? Nothing. What treatment will I add because of first degree AV block? Nothing. Atropine? No. Pacemaker? No. Nothing. I do nothing for first degree AV block. Second degree AV block. Second degree AV block. Oh, I'm dropping a beat. P, QRS, T, P, drop. P, QRS, T, P, drop. Well, it's dropped beats. PR prolongation by itself. First degree AV block doesn't drop a beat. Second degree AV block drops a beat. Now there's two different types of second degree AV block. They would be type 1 and type 2. That makes two types. Mobitz 1 and Mobitz 2. Okay, Mobitz 1 is also known as the wanky block. Okay, now third degree AV block. Oh, that's a P, that's a P, that's a P, that's a P. The P is in there somewhere. That's a P, that's a P. The PR interval is regular. The PR interval. See that interval from there to there, from there to there, to there to there? Each of these P's intervals, P to P intervals, I should say, each of these P to P intervals, excuse me, each of these P to P intervals is the same. The P to P intervals are the same. The R to R intervals are the same. The P to T, the P to P, the R to R. The P to P, the R to R. The P to P, the R to R are staying the same. So the R to Rs look regular. But this is like a bad marriage. This heart needs couples counseling. So, QRS, how come you don't beat in sync with the P wave? How come you're not keeping in track with the atrium? The atrium beats whenever it wants. Doesn't ask me, just beats, shows up early, shows up late. What am I supposed to do? So the P to P intervals are regular, the R to R intervals are regular. They just have no relationship to each other. Third degree or complete AV block. What's the best therapy for a third degree block? It is symptomatic atropine. Asymptomatic, straight to pacer. Third degree AV blocks, also known as complete heart block. Always need a pacer. It doesn't have to be first. It doesn't have to be first. We have a 57-year-old guy who's post-MI, and he's feeling light-headed, and he's feeling confused, and he's got a blood pressure of 70/40, and he's got third degree AV block. Does this man need a pacemaker? Yes, he does. But the question is this: what's the next best step in the management of this patient? What is the next best step in the management of this patient? He does need a pacer, and a pacemaker is good, but atropine is gooder. Pacemaker is good, but atropine is even more important. And that's why it is atropine for any symptomatic bradycardia, pacemaker for a persistently, continually. I give you atropine and you're still lightheaded, pacemaker, make me a match, find me a rhythm, catch me a catch. So that means that if you have a symptomatic bradycardia, atropine is first to try and speed up the heart rate. If it is not effective, then a pacemaker. Pump function. Well, it means that as my heart dies, it doesn't contract. That's shocking. Mechanical disruption. That means valve rupture, septal rupture. Valve rupture, septal rupture. Electrical mechanical dissociation means that the electrical system is firing, but there is no muscular contraction. Now, papillary muscle rupture. Isn't this a beautiful picture? Okay, what a beautiful, pretty, old-fashioned picture. So this is basically showing, wow. You know why that picture is in there? Because I think it's pretty. And that's the main reason it's there. Okay, papillary muscle. See, that's the papillary muscle. These are the chordae tendineae holding on to the valve. Papillary muscle with the cords holding on to the valve. When you're walking with a float in the Macy's Thanksgiving Day Parade, how is it that the floats don't float away? Because lots of people are on the ground holding the cords that hold the balloon. Well, the person holding the cord is the papillary muscle. The purple holding the cord to the balloon is the chordae tendineae. And every once in a while, my whole childhood, for instance, was spent watching the Thanksgiving Day Parade, hoping that one of them would rupture. And we can have a flyaway balloon. And that's a flail leaflet. If I infarct the papillary muscle, the chordae floats away. And the chordae floats away, and so does the balloon. Flail leaflet, flail leaflet, flail leaflet. Well, how am I going to tell the difference between the rupture of this papillary muscle and chordae tendineae and, for instance, the rupture of the septum? How will I tell the difference in someone between the rupture of a chordae tendineae and the rupture of a septum? In other words, valve rupture causes shortness of breath, hypotension, tachycardia. Septal rupture causes shortness of breath, hypotension, tachycardia. They both cause rales, they both cause shortness of breath. How are you going to tell them apart? They both cause a murmur? And the answer is that you will be able to tell them apart based on the fact that septal rupture has an increase in saturation as you go from the right atrium to the right ventricle. It's a step up in O2 saturation. How do I tell before I get the echo, which is the most accurate test? A step up in O2 saturation. A step up in O2 saturation. Okay? It's a step up in O2 saturation. Okay? The step up in O2 saturation is how you'll be able to tell. Because unless you put your lungs at the level of the tricuspid valve, why is it that the oxygen saturation is going up between the right atrium and the right ventricle? Because it's mixing in. Mixing in. These sound very similar. Murmur, rales, hypotension, confusion. How are you going to tell them apart? Step up in O2 saturation. Well, the complications of ischemia. The specific name of the inflammation of the heart causing pericarditis after a myocardial infarction is Dressler syndrome. For a reason that nobody knows. When the heart dies, it releases antigens that provoke an antibody response against the pericardium. Why is that? It's just the way it is. Por eso sí que es, man. Por eso sí que es. It is what it is. Why? I don't know. Figure it out, go to Stockholm, get a Nobel Prize. The person is put on non-steroidals and aspirin, they still have pain. The answer is steroids. Well, the problem with the heart is that even if the heart doesn't die, but it just gets an outpocketing, because it's weak, kind of like the weak side of a bicycle inner tube, what happens in that weak outpocketing is that you can develop a clot in it. Mural, the word mural, what would you call a painting on a wall? Would that be a mural? Mural is a $5 word for wall. Mural thrombi, wall thrombi. Where is it? It's in the wall. Heparin, coumadin, heparin, coumadin. Now, sudden cardiac death. Now, this is going to be a toughie. Ready? You're going to get it wrong, but let's get it wrong right away. 70-year-old guy, let's kill off another guy, has a myocardial infarction. He develops VFib, VTAC on the first hospital day, and he is shocked back into sinus. What is the best long-term therapy for this man's arrhythmia? What is the best long-term therapy for this man's arrhythmia? What is the best long-term therapy for this man's arrhythmia? And the answer is beta blockers. Not amiodarone, not procainamide, not lidocaine. Ready? And not an implantable defibrillator. The implantable defibrillator is for people who were doing nothing and they got an arrhythmia anyway. That's who the implantable defibrillator is for. Yo, doc, I was minding my own business, wasn't doing anything, and all of a sudden I felt like I died. Why? Because you died. VTAC, VFib, unprovoked, implantable defibrillator. Ischemia, fix the ischemia. Cocaine, contusion, fix the cocaine and the contusion. The management of this arrhythmia is to fix the ischemia, not put in an implantable defibrillator. Ooh, inferior wall MIs. Inferior wall MIs, 40 to 50% are associated with a right ventricular MI, which results in hypotension. What do you do? Well, normally the best initial test is right ventricular leads. Normally leads go like this, V1, 2, 3, 4, 5, 6, across. You flip them across to the right side of the chest. Best initial test, right ventricular leads. Therapy for right ventricular infarction? Water them. Water them. Water, water everywhere, and not a drop to drink. So the answer is water them. Bring up the pressure. Now, the two most common fatal complications of MI are VTach and VFib, and here's what they look like. Now, what you'll see here is a wide complex tachycardia. Wide means a QRS greater than 120 seconds. 100 milliseconds, I should say. That's 2 minutes. 120 seconds. That's long. 120 milliseconds. QRS greater than 120 milliseconds. And it's regular. If this person is hemodynamically stable, amiodarone lidocaine. If this person is hemodynamically unstable, shocky. VFib always gets shocked because there's no such thing as stable ventricular fibrillation, because you're dead. Well, I suppose that's stability of a kind. Honey, I want a stable relationship. You mean you want me to be dead? No, 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 no. See, VFib is either the most stable or the least stable. You always shock because you're always hypotensive. VFib, always shocked. VTach, stable. Lidocaine, amiodarone, procainamide. Unstable, shock. What do we mean by unstable? Chest pain, not perfusing the coronaries. Shortness of breath, not getting the blood out of the lungs. Hypotension, systolic less than 90. Hemodynamically related confusion. Chest pain, shortness of breath, hypotension, confusion means you're not getting enough. Very good. Perfusion. You are so smart. You know, you don't even need me at all. You're like a genius. That's amazing. You know what I mean? I mean, my object here is to get it so that you don't even need me anymore. That's wonderful. Wonderful. You're doing so great. Come here. Come here. Come to the hug. Come to the screen. Give me a hug. Come on. Reach around the screen. Kiss the screen. I know it's glass, but come on. Kiss the screen. Thank you. Well, here we are at the other aspects of chest pain that are not from ischemia, not from atherosclerosis. Prinzmetal's angina. Hey, that gives pain. That's why it has the word angina on it. Here's the question. What is the most accurate test to diagnose Prinzmetal's angina? What is the most accurate? Well, it does give you ST segment elevation, but that's not the most accurate. Hey, if I come to the emergency room with ST elevation, you should treat me like I'm having an infarction. Don't go, it's probably Prinzmetal's. Give him a calcium channel blocker, because then I'm going to die. How do you diagnose Prinzmetal's most accurately? The answer is angiogram. Angiogram is the only way to know for sure. It's a vasospasm, yes, but how do you know? Because it's associated with ST elevation. Guy comes in with ST elevation and chest pain, you better give him thrombolytics and angioplasty. Except that this one occurs at rest, but unstable angina occurs at rest. How do I know it's not unstable angina? We're in ST segment elevation MI at rest. And the answer is not awakened from sleep. That could be a myocardial infarction. The answer is more in females. No, that's not good enough. It's true it's more in females, but it's not good enough. The answer is that the angiogram and the stress test are normal. All these things, ST elevation, rest, awakened from sleep, females, that's true. But angiography normal is the most accurate method. Ergonovine is stimulant testing. I squirt some ergonovine into your blood, into your coronary artery, and it should provoke vasospasm. Hey, a guy comes and he's short of breath, and you're not sure if he has asthma. What test do you get to provoke the guy's bronchi to see if he has asthma? Methacholine stimulation. Methacholine stimulation. Methacholine stimulation. Now, what's methacholine stimulation for your coronaries? Ergonovine. Ergonovine. The treatment is calcium channel blockers and nitrates. How do I tell it's Prinzmetal's? Not until I get an angiogram, man. The most important thing with acute coronary syndromes is 1, the pain. Is it positional pleuritic or tender? It's not ischemic. Next point. It's real. Get an EKG. The EKG, I got a real story and I got an EKG. It shows ST elevation, aspirin and thrombolytics, aspirin and angioplasty. No ST elevation, aspirin and heparin. Remember, for non-ST segment elevation MIs, the major management is heparin. The most accurate test is an angiogram. When you have a person with a chest syndrome, but they have no acute symptoms now, the test is a stress test. Now, acute coronary syndromes are the single number one most common cause of death in the United States, more than number 3 through 10 combined. So therefore, one of the most likely questions for you, ones you may not even remember, are these acute coronary syndrome questions. And that's the end of acute coronary syndromes.